Let's take a look at the two parameters of dysfunction in further detail. In systolic dysfunction, it's the fact that, well, the heart's not pumping, period. Now, with that said, there's an all-important graph from physio that explains the pathology beautifully. Along with this, well, you want to start thinking about what kind of pharmacologic agents you want to plug in here. So with this graph that you've seen in every single medical textbook, clinicians and professors of all type have been discussing this matter for years. Let's just put all this together so that you have a firm understanding as to how this graph operates. Well, before we do any of this, it's like a bird's eye view of the cardiovascular system. It's the only way that any of this graph will make any sense to you. You're not sitting there just memorizing like you would perhaps with physics, because that's not what medicine is. Yeah, sure, you can incorporate it, but ultimately it's what's going on in the body, huh? So, three-dimensionally, bird's eye view of the heart is a continuous circuit, isn't it? A continuous circuit. What does that mean? From the left ventricle, blood is being ejected out, but it's completely dependent on the amount of blood that's returning to the heart, isn't it? So therefore, the venous return to the heart, let it be from the pulmonary veins for the left side, or the supravena cava and the IVC for the right side, is then going to equal the amount of blood that is being ejected out, and that then gives you your steady state, doesn't it? How in the world could you possibly have an increase in ejection of blood with cardiac output if you don't have enough blood that is returning to the heart? How is that even possible? It's not. So therefore, the fact that you're looking at the cardiovascular system as being a circuit in which everything is just a perfect circuit, a circle of flow, return, is our graph. You'll see exactly what I'm referring to as we dissect this graph in great detail. First and foremost, on the x-axis, remember, any graph that you get in pathology, in physiology, what have you, you have to dissect and take a look at the parameters. The x-axis represents what? Atrial pressure. In other words, this would be the volume. Okay? Whereas the y-axis here would represent two different things. It would represent the cardiac output. Number two, represent the venous return. It has to. Remember, I told you, what blood comes into the heart is equal to the blood that's ejected from the heart. How do you increase venous return? Simple question. How do you increase venous return? By getting more blood out. So the more that you increase your cardiac output, the more that you increase venous return. Do you see that now as being a objective, as being a bird's eye view as to what's going on with the circuit? Let's dive into this further so that you will. Next, the three questions that you want to ask yourself with this graph, or the three parameters that you truly want to get a firm handle of from physio, is performance is equal to changes in cardiac output or contractility, and you have your volume. Is that clear? Where does performance come in on this graph? It's the y-axis. You keep it separate from contractility, please. What do I even mean? Well, I want you to take a look at that cardiac output curve where it says normal. You see that? Well, that cardiac output where it says normal, anywhere that you would be on that particular curve, answer this question for me. Are you changing contractility if you move to the top of that curve, by the plateau perhaps, or down at the bottom? Are you changing contractility? No. As long as you're on that curve and only on that curve, without shifting of that curve, then contractility remains exactly the same. Is that understood? If it hasn't, then make sure that you understand it now. Does that curve, where it represents cardiac output, is that venous return? Not at all. It's strictly cardiac output. It's strictly contractility. Now, performance. As you go up and down that curve, contractility remains the same, but then what changes? Performance. Interesting. Remember that from physio. So performance will change as it moves up and down, but contractility remains the same. So what's the other parameter that you need to add in here so that all of this makes further sense? It's your vascular function curve. It's your venous return, isn't it? So your vascular function curve would be represented by what you're seeing here as an intersection point. So where it says normal, That's your vascular function curve, and that represents the venous return. And your cardiac output is only equal to the amount of blood that's returning to the heart. And that gives you approximately a pressure of 2 millimeters mercury. And that's normal, isn't it? Think about that for a second. In your atria, aren't you supposed to have low pressures? Of course you are. And even if it rises to 2, that means that that's high enough pressure where it's allowing for cardiac output to continue. So that's perfect at steady state. So now, I want you to take a look at vector A. Vector A represents what? It causes a decrease in your y-axis. So what are the three things that we're looking at? Performance, contractility, and volume. Performance equals contractility and volume. So now, vector A shows a decrease, a downward movement on your y-axis. What happened to performance? It decreased. How did the performance decrease? Was it due to volume? I'm sorry, where was volume on this axis, on this graph? It was the x-axis. And as you move from left to right, what happens to volume? It increased. If you increase volume, how in the world is that going to decrease performance? What do you mean? Take a look at vector A. Don't look at me yet. Every once in a while, perhaps. But vector A represents a decrease in performance, but that is not due to an increase in volume. That makes no sense. Because you know if you increase the volume, you should increase the stretch. If you increase the length, then you might increase the tension. Welcome to Mr. Frank Starling relationship. So, what then caused a decrease in performance, please, in vector A? Was there a shift in that contractility curve? Yes, there was. What kind of shift? A clockwise shift, right? Isn't that how they'll describe it? A clockwise shift, a negative inotropic effect. What caused this? Oh, maybe myocardial infarction, right? And myocardial infarction has what type of effect on your heart? A negative inotropic effect. Is that clear? So a decrease in performance due to decreased contractility. Stop there for a second. Now, look at me. Because we're going to predict a few things before you take a look at the graph. If your heart starts failing, and it doesn't want to move forward, it doesn't want to eject the blood forward, what kind of dysfunction is this? What's our category? What's our topic? A systolic dysfunction, isn't it? It's a systolic dysfunction because it doesn't want to move forward. The blood doesn't. It can't because you lost the ability to contract. So now what do? What happens? There's an increased amount of blood in your heart, isn't there? There's an increased amount of blood in your heart. And when there is an increased amount of blood, what then happens to the pressure? It increases, doesn't it? When there's increased amount of blood and there's increase in pressure and it doesn't want to leave, then what happens to venous return? The blood is stuck in the heart. How could you possibly have more venous return? You don't. You have a decrease in venous return. Let's take a look at the three changes that are taking place with vector A. Number one, a decrease in performance due to decreased contractility. How can you confirm that? An actual shift of the cardiac output curve. Number one. Number two, there's more blood left in the heart. How can you confirm that? The pressure in the heart should increase. Take a look at the x-axis, moved from 2. In which direction are you moving? From 2 millimeters mercury, you move to the right. That's number 2. You've increased the pressure. And what's number 3? Venous return. Think about this. More blood is left in the heart. So what happens to venous return? It decreases. Where is venous return on this graph? On the y-axis. And if you take a look at vector A and you move down, what happened to venous return? Aha, it decreased. You see that? Good. So what are we referring to here? A systolic type of dysfunction. Now we're going to skip over into compensation a little bit. And where's my blood? Excuse me. Let me rephrase that. Where's my fluid? Where's my actual fluid? What do you mean, Dr. Raj? I mean to say that if you have congestive heart failure and you have left-sided heart failure, where might my fluid be? You've heard of edema, have you not? Increased hydrostatic pressure, pulmonary edema. And we'll talk about signs and symptoms. What if it was right-sided heart failure? Then what are you looking for? Once again, edema. Where am I? Positive JVD, and then what might you have down in the lower extremity? Pitting edema. Transitate. What's my point? The point is this, is the fact that when you have a negative inotropic effect and that fluid is being shifted out, then how are the kidneys going to respond? If the fluid is moving out into the interstitium, there's less effective circulatory volume, isn't there? So when there's less effective circulatory volume, heading towards the afferent arteriole, what's going to be released from your juxtaglomerular apparatus? It's called renin. Hello, renin. And then we have the RAS system, which is going to kick in. And here comes maltodextrin. Why? Now, this is the compensation you're paying attention to. Not the neuroreflex. This is congestive heart failure. The neuroreflex is, at this point, for all intents and purposes, it's null and void. So we get into aldosterone system, don't we? How can you confirm that? I just showed you the patient conceptually. So with this aldosterone, what is it trying to do? It's trying to restore some of that contractility. Let's ask the same questions again with aldosterone. You ready? With aldosterone, where are we working? Working the collecting duct. What's the name of that cell? It's the principal cell. What is it doing? It's stimulating sodium-potassium pump, or maybe ENaC. Are you picturing that? In the collecting duct of your nephron, way distal in the nephron, we have the principal cell. On the basolateral membrane, you have a sodium-potassium pump. It'll stimulate it so that it reabsorbs sodium. On the luminal membrane, or the apical membrane, it stimulates ENaC, or epithelial sodium channel. All in the hopes of doing what? Reabsorbing your sodium. Isn't that what aldosterone does? Of course it does. It reabsorbs the sodium. In addition, what are you going to do with volume? You're going to retain it, aren't you? There you have it. Now you have your volume. That's increased. When you increase your volume, then now what should happen? Take a look at vector B. So now with vector B, we have an upward swing, right? We have an upward movement of your y-axis. So what happened to performance? Increased, because it's the y-axis. Performance increased. Why? Why? Was there an increase in contractility? My goodness gracious. Take a look at that curve from vector A. As you go from vector A, and where we just moved down to a negative anthropic curve, and we've moved up to through vector B, have we changed or shifted your cardiac output curve? No, you haven't. So contractility remains the same. If you want to confirm that, go back and take a look at physio. This must be understood. So what in the world increased the performance in vector B? It's the fact that you increased the volume. How can you confirm that? Take a look at the x-axis. Vector B, you moved further to the right. You increased the volume, thus you increased the performance. How can you confirm that further? Once again, in physiology, isn't this amazing that you're able to integrate all this now in the setting of systolic dysfunction? With all of this, when you have an actual change, listen to what I'm saying, x-intercept. When you have an actual change physically of the x-intercept, then you know that you have an increase in volume because you shifted to the right. Thus, in the process, in this patient with what's known as compensatory congestive heart failure, we do have a restoration for this time being of some of this performance. But our contractility is still pretty much overall, tell me, overall contractility compared to normal, decreased. What do you want to do now at this point? His patients come in. Maybe you want to start thinking about giving drugs. What kind of drugs? Well, you want to try to give those drugs in which it decreases mortality, right? It inhibits remodeling, right? And that'll be our point. So later on, at some point, when we do a little bit of pharmacology, we'll take a look at those drugs. Well, depending as to what they're going to ask you. Maybe they'll ask you, well, what kind of drug will increase anatropy? And you will correctly say digoxin. What kind of drug is going to take care of your preload because of pulmonary edema? Isn't that a symptom that you want to take care of? My goodness, my patient can't breathe properly, especially at night, wakes up and says, Doc, I have to run to the window. Open up the window real quick because I'm gasping for air. So you want to take care of some of the pulmonary edema? Why not a diuretic such as furosemide? Or maybe perhaps you want to decrease mortality, increase survival. Welcome to metoprolol, beta blockers. Beta blocker. Be very careful, though. Be very careful. And the reason I say that is because if you have decompensated type of congestive heart failure, you might kill your patient. So strict supervision is absolutely necessary.